So going straight to my topic, OCT angiography in central serous chorioretinopathy. Does it help identification of early neovascularization? So let's start with a case. A 49-year-old male with defective vision in the left eye since 1.5 years, 6/18 vision, and he was referred to us for possible treatment with photodynamic therapy. He had a very recent fluorescent angiography which showed a subfoveal RP diffuse leakage suggesting a chronic CSR. The right eye was normal except for a pachychoroid and dilated outer choroidal vessels in the right eye. And coming to the left eye, patient had a subfoveal flat irregular PED which on structural OCT showed subretinal fluid and a shallow or flat irregular PED with moderate internal reflectivity. So as you can see here, there is a pachychoroid. You see this flat irregular PEDs with internal reflectivity overlying a pachyvessel and attenuated choriocapillary layer under that flat irregular PED. So the superficial plexus, deep plexus were normal. The avascular retina shows this choroidal neovascular membrane, and this is a 3 mm and 6 mm slabs of OCTA showing this network there. And when you overlap that flat irregular PED to this OCT angiography, this is a pachyneovasculopathy overlying a pachyvessel and attenuated choriocapillaries, and the patient underwent treatment with anti-VEGF injection. So now the described entities of OCT angiography in chronic CSR include these ill-defined dark areas which are diffuse and low detectable flow areas. And it has been shown that choriocapillary attenuation overlies the pachy disease. And most of these dark areas usually corresponds to subretinal fluid overlying in those areas of dark areas. And these dark areas could have these dark spots which are well delineated areas of no flow, which either overlies the area of RP hyperplasia or pigment epithelial detachments. So the abnormal choroidal vessels that can be seen are two types of high flow tangled pattern. The first pattern is a ball of wool pattern which corresponds to the choroidal neovascular membrane, and the second pattern is a loose indistinct tangled pattern which may or may not be a choroidal neovascular, early choroidal neovascular membrane. So in general, around 25% of the chronic CSR shown to have type 1 CNVM. So now the question is, why do you need OCT angiographies in picking up this early neovascularization? We all know about the type 1 neovascularization, which is a well-known complication of chronic CSR, but it can arise in pachychoroid eyes which has not manifested frank subretinal fluid when we call pachyneovasculopathy. That is the second situation. And why it is important is because there is a lot of overlap of clinical picture as well as imaging features between these two entities, chronic CSR as well as CNV, early CNV complicating a CSC. So the diagnosis can be challenging because the PEDs, presence of SRF, intraretinal fluid, cystoid macular degeneration, as well as the retinal RP atrophy are common to both these entities, and the fluorescent most of the times just show a diffuse irregular RP leaks. And even more, the ICG angiography, which I will be showing later, will just show multifocal areas of choroidal hyperpermeability and not a frank or subtle CNVM there. And to add to the situation, the early pachy CNVs usually do not present with subretinal hemorrhage as a presentation. So we need a diagnostic entity which specifically picks up these neovascularization. So looking at some of the studies, ICGA-based studies, as the ICG angiography, around pickup rate is around 25% in chronic central serous retinopathy, and many of them shows polypoidal lesions on OCT, on ICG angiography. So the issue is that this ICG in these eyes shows choroidal hyperpermeability with the RP alterations and RP degenerations do not pick up this subtle neovascularization at the macula in this chronic in this pachy or neovasculopathy or chronic CSR situation. So Dr. Freund and group show that Dye-based angiography picks up around 30% of these neovascularization, whereas OCT angiography in a pachyneovasculopathy situation, 95% is the pickup rate of choroidal neovascularization. And flat irregular PEDs like this has a greater diagnostic significance of picking up type 1 neovascularization on OCT angiography, whereas the dye-based angiography may in fact underestimate the prevalence of neovascularization compared to OCTA. And Dr. Nadia Wahid from New England Medical Center, they looked at specifically the SD-OCTA sensitivity in picking up choroidal neovascularization associated with chronic CSR, and dye-based angiography picked up 30% of these eyes, whereas OCTA picked up comparison to dye-based angiography 100% of the eyes which had CNVMs and excluded 100% of the eyes of chronic CSC without CNVM. So why this high sensitivity and specificity in CNV in CSR? Because rarely these neovascularizations in CSR present with subretinal hemorrhage, massive subretinal hemorrhage compared to neovascular AMD. And also these fine vessels which lies between the RP and the Brooks membrane are usually not picked up with a conventional angiographic imaging. So also comparison between ICG angiography and OCT shows that ICG angiography most of the time shows choroidal hyperpermeability, whereas around 60% of the times the OCTA picks up these CNVMs under the macula overlying this flat irregular PED or called as fibed. And the ICG angiography do not show these, may miss these CNVMs under the RP detachment. So, and looking at another subset of chronic CSR, that is cystoid macular degeneration. Jay is not here. Jay and colleagues have shown that in cystoid macular degeneration, in fact, 50% of the eyes do have flat irregular PEDs which have these subtle new vessels picked up on OCT angiography. Now the question is, do you really need to treat all these fine neovascularization picked up on OCT angiography? The importance is that 30% of them have this type 1 pattern. What is this type 1 pattern? They have a well-defined lazy pattern with dense capillary network and a peripheral anastomosis. That is a type 1 pattern which really require treatment with anti-VEGF agents, whereas the loose network or indistinct tangle pattern which I mentioned earlier may even be observed in that setting. So coming to the fellow eyes, now one eye has showed a CNVM in CSR. It has been showed that with OCT angiography of the fellow eyes, almost 50% of the eyes have this flat irregular PEDs or so-called fibed. These fibed have 50% and half of them, around 25% of these fibed has this neovascularization that is picked up on OCT angiography. As you can see here, this is a frank neovascularization in one eye. The other eye has got a flat irregular PED having this loose network under the flat irregular PEDs. So it has been shown that swept source OCTA machines like the Plexelite Zeiss is superior to the SD OCTA in picking up these neovascularizations because there is a reduced sensitivity roll-off. That is, as the depth of lesion concerned going to the choroid, because the longer wavelength of the light used and deeper penetration, the swept source OCT has been shown to be better in picking up these subtle neovascularization compared to SD OCTA. So I would conclude OCTA picks up early detection and prompt treatment of these neovascularization in chronic CSC as well as pachyneovasculopathy. And OCTA has near 100% sensitivity and specificity in picking up the pachy CNVs compared to ICGA. And the fibed or flat irregular PEDs on structural OCT has a diagnostic value of around at least 35% in indicating this neovascularization. The OCTA avoids the burden of intravenous dye injection and the risks involved with dye injection. Therefore, it should be considered as the first step in detecting these CNVMs in CSR. However, currently the drawbacks include a learning curve and manual segmentation that is required, and the high cost of swept source OCT angiography machines which are required to pick up at a higher rate these lesions. So thank you.